Good afternoon. I'm Dr. Anthony Cristillo, Digital Health Partner at Guidehouse. Welcome to CDO Magazine's podcast series. Today, I have the distinct pleasure of chatting with Dr. Stuart Knechtle. Dr. Knechtle is the William R. Kennan Jr. Distinguished Professor of Surgery at Duke University, Adjunct Professor in the Department of Medicine, and Organ Transplant Surgeon. Good afternoon, Dr. Knechtle.
Good afternoon, Dr. Cristillo.
Dr. Knechtle, let's start off with a question about data. Given your expertise and commitment to clinical research, clinical care, and specifically organ transplantation, what does a data-driven culture mean in this context?
Well, in transplantation, we are accustomed to living in a data-rich world. We are probably, of all the medical specialties, the one that is most accustomed to having its outcomes and quality reported annually and visible using a national database called SRTR, or Scientific Registry of Transplant Recipients. That has been a huge benefit to the transplant community and, of course, to patients by driving quality improvement and standards of care. So we are accustomed to having all of our data reported and visible to the public.
Excellent. Let me pull on a thread. A moment ago, you spoke about data quality. I would have to think that data quality, interoperability comes into play with such a vast amount of data and the need or drive for data-informed decisions. Is this an area that we feel needs more attention, or do we think there are other aspects of data that should be prioritized?
Well, we're moving into an era where data could be used much more with greater benefit, I think, to patients and to the caregivers as well, because although we have a huge database of patient information that's located at the transplant centers, for instance, and then we have national data available that's aggregated on program performances and practices, we're moving into an area where instead of individual decision making every time we have an organ offer and a recipient, where the performance and practices of surgeons and transplant centers with regard to organ acceptance, for instance, could be standardized and made much more even. And perhaps such tools could be used to create a more equitable system as well. There have been areas of equity identified in our field that need to be addressed urgently, because we want to be able to offer transplantation equitably to all patients in the United States. That would be one example. And in order to even out acceptance criteria, for instance, for organs, and to allow centers to manage their organ acceptance more evenly across their different surgeons and across over time, it would be a great benefit to have integration of the donor information that comes currently through UNOS and UNET to integrate that information with transplant center information in order to look at outcomes. There may be opportunities, for instance, to see if Duke, my center, rejected an organ and it was transplanted successfully elsewhere, how can Duke learn from that experience and perhaps change its own acceptance criteria so that we don't miss the opportunity to give that organ to a patient?
I think what strikes me about your response is you touched on leveraging that data for insights, for predictive analysis, to a level prognostic analytics, and in the context of, or in the goal of improving outcomes, that feedback loop of lessons learned. So there's a lot of sort of rich information, it sounds like, that will come from these disparate data that gets integrated and leveraged I guess my next question is, what are some of the challenges associated with it? Because you're painting this beautiful picture of a promised land, the future of really leveraging this data. Where are some of the challenges, and how can we do things differently to make that a reality, that use of data?
That's a great question. Well, one example I could use is that we currently begin to collect data on transplant patients from the time of their listing. That means that they've already been through a referral process and an evaluation process before they're listed that we do not collect data on. In order to address equity issues and to address timely referral of patients of different types, it would be extremely helpful to know what is happening with respect to referral. Which patients are being referred, which ones are not being referred. And then the evaluation process differs probably slightly from transplant center to transplant center. It would be very helpful to be able to track a patient's process through their evaluation to see when do patients continue and advance in the evaluation process, and when do they not meet criteria and leave that evaluation process, and so forth. How long does that process take for different transplant centers? That would give us granular data on referral practices in the United States across different racial groups, genders, and whatever the demographic parameter you choose to look at. And then what happens in that evaluation process? How do transplant centers differ? And what is the outcome? We would have to back up our data collection through those two additional processes in order to be able to answer some of the equity questions that are being asked currently. So that is a data collection opportunity, I think, that exists. And of course, to continue this conversation, you would also want a platform that would be able to incorporate financial factors. What happens when the patient's insurance changes? Can you see that information in real time and address it more effectively? Could you build a platform that patients could access, and it would be actually useful to them to know what's going on with respect to their evaluation, listing, offers, and so forth? And could you build a system that tracks these patients long term through the transplant process and beyond, such that you would have all of that data in an accessible manner broadly?
Your answers strike me that they open up such a Pandora's box of complexity, and I mean, wonderful insight, but also complexity. The idea, which is phenomenal, of sort of leveraging this disparate data for different stakeholders, right? You speak of insight into health equity, but also from an operations perspective, bringing that financial data in. And I would take it one step further and say your methodology, your thought process is brilliant insofar as improving operations and logistics and communications within the organ transplant community. The purists, the data purists, those that deal with data governance, standardization, harmonization, sensitivity, security, will say that the underlying foundation is of critical concern. In other words, how do we achieve that? And with the idea that a lot of this data is sensitive. You've got PII and PHI considerations, some cases GDPR or GDPR-like sensitivities in terms of the privacy of that information, sensitivities around the financial data. How does one sort of move forward in this sort of complex environment? Is it an understanding of this that is the starting point to sort of make use of it? I guess I'll open that up. What are your thoughts on that?
Well, of course, you're right that the data needs to, the patient information and healthcare information needs to be secure. And so we would need to follow national guidelines with respect to FISMA, the national system of data security. And we would probably need to achieve a FISMA, probably moderate degree of security in order to protect patients' confidentiality and so forth.
I think you've given us a lot to think about in terms of the challenges and opportunities that exist. And so I just wanted to thank you for spending time with us today and educating us. Appreciate
My
it.
pleasure, Tony, and thank you for your partnership in these efforts.
Thank you.